anatomical review slide showing us the anatomy of the proximal tibia. And what we wanted to do, and the main focus of this talk, is to come up with a technique that would make osteotomy safer. How can we, if you sat in a room with osteotomy surgeons and you said, you know, hands up who's seen a vascular injury, sadly, a lot of hands would go up. It's something that does happen, even in expert hands. So we decided to set about coming up with a strategy to tackle this problem, and we developed a new retractor system with NuClip. And we developed a new technique as well to actually manage the MCL and deliver that. So we got together with myself, Ronald, Christian, Rags, Sachin from India. We got together with NuClip and we started to think about how could we make osteotomy even better. So I started working with the small type 1 NuClip plate. I used it for 8 years, 9 years. I had no issues with it, tiny little thing. And then we developed the type 2 plate, which you can see top left. And there's a whole family of plates. And they have really taken osteotomy to the next level. And in fact, they have some fantastic innovations coming through in the not too distant future. Here, for instance, the ACL plate that allows you to make a tunnel for your, make a plane for your ACL. We have femoral plates, medial and lateral. We have PSI guides. And this is very popular, is the PSI system, because of the following, because of those reasons, its accuracy and its precision. I said to them, look, why don't we come up with an idea on how we can open and close the osteotomy and control it. So we developed these laminar spreaders, which allow us to place little ball-bearing K-wires outside of the osteotomy and physically open the osteotomy and compress it with this simple device. This will be coming soon. This will get rid of towers, locking towers. So this quick drill guide comes in 3 pieces. It clips onto the plate. It allows you to fix the middle section to the bone, and then you can use the towers to drill. You take the towers off, you can place the screws. It makes the surgery much quicker and much more efficient, which is what we want to do for our patients. So this will be available very soon. Here you can see us fixing it to the saw bone, and you have that 2 pieces, top and bottom. You can drill, and you don't need to use the locking tower. You take it off, you put your screw, you go distal, you drill, and so on. So the new concepts that I want to focus on, number 1 is the hinge, number 2 is the MCL, and number 3 is how do we avoid a neurovascular injury. So the hinge, this is a problem, and it's actually, it was the CEO of NuClip, Greg, who's just so completely caught up. He's not a surgeon, he's a businessman, but he's so caught up in osteotomy. His idea, it was his idea to place a K-wire at the hinge, and what they found when they did biomechanical studies, Matt and Seb Perrin, was it increased the load to breakage 880% just by placing a simple wire. So it was actually Greg over here on the left that actually came up with that idea, top left, and Seb Perrin and Matt then went on and did the basic science. And the idea is that you place these wires, they're very easy to do. Most of us find placing a K-wire in the middle of a bone straightforward, and this massively increases the strength of your hinge as you perform your osteotomy surgery, closing or opening femur or tibia. So then we came up with a concept of a hinge screw, and the gentleman in the middle there was supposed to be here today, Conrad. Sadly, he couldn't make it. He's going to come next year for sure, and Rags. And Conrad had a DFO, Christian did the surgery, and being a surgeon, of course, he was non-compliant, just like Zayed doing his wakeboarding. He fell over and fractured, as you can see, and Christian had placed 2 hinge screws, and Conrad, fortunately, didn't have any issues and went on to heal uneventfully and sent us some lovely images of him snowboarding. And if you can see here on this short video how enormous in cadaveric bone this opening is with the hinge still intact by placing a simple screw. So the actual hinge fracture classification was described by Professor Takuchi, type 1. Everyone gets this at an X-ray level. If you CT everyone, you'll see everyone has a type 1 fracture. We're worried about type 2 fractures that go down into the proximal tib-fib joint, and of course we need to deal with the type 3s. With the type 1 now, we routinely use a hinge screw for all of our cases. For the type 2, we plate the other side, and for the type 3, we actually, of course, need to reduce if there is a type 3, we need to reduce the osteotomy and then fix the problem as we would with any fracture by putting a palisade of screws across and then go back and do the osteotomy. So, type 1 is not a complication. It's inevitable. And if we look at the Tomafix system, we always talked about this golden screw that allowed us to achieve indirect compression. But of course, we're all fracture surgeons, and we don't fix our fractures by indirect means. We fix them by direct stabilization, which gave us the idea for placing first the wire and then the screw and developing this hinge screw concept. And here is a patient, tibia, Christian, our post-op ward around 8 o'clock in the morning, fully weight bearing. He's had bilateral osteotomies, much more comfortable when we did place a screw across that hip. Here is a distal femoral osteotomy. Here are the steps, 2 wires converging. Again, the wire in for the hinge screw, and you can see us placing that wire for the hinge screw here on the image intensifier. Again, some steps of the osteotomy. And it's very simple to place these screws, and in fact, maybe the answer will be 2 screws, but at the moment, routinely, we're doing 1. And now it comes as a kit that has been developed by Nuclip, and everything is included in the kit, and it has this very clever multi-purpose screwdriver that's also a measuring device, and it comes such that you can place the wire, you can measure, and all the pieces are beautifully presented such that you can do the kit with this disposable equipment. Again, you can see this multi-tool measuring device. Type 3, we need to place a palisade of screws. So what about preventing a neurovascular injury? I think this is a good invention. It's quite expensive. It's a precision saw blade that has a limited excursion within the cartridge. So when you place this in the bone, you know there isn't going to be a big throw on the saw. It's going to be limited. I think this is a very good device. It's expensive, but we do use this as a routine. So then we came up with this idea of a retractor. So what we wanted was something that had a piece of metal that would allow the surgeon to identify it with X-ray. We wanted to be able to place it against the bone, and we wanted to lock it into position, and then create a safe avenue for the surgeon to then come in with the saw and make his main saw cut. And yeah, we'll move on. This is cadaveric, of course, but what we want to avoid is damaging the popliteal vessels. And one thing that we've learned from anatomical studies is there is an aberrant branch that sometimes sits deep to the popliteus, physically on the bone. It's actually quite a large branch, and when you hit it, you can get quite torrential bleeding. It's not the main artery, but it still requires treatment. And I think a lot of patients that wake up with swelling and pain after an osteotomy have had damage to this vessel, which creates some of that huge swelling that we did see historically before we understood this. So we want to avoid this. And as I say, we came up with this concept. Here you can see in a cadaveric specimen, you can see the radial opaque component of the saw. And this is a video just taking us through some of the steps. Now, within this video, we're also going to talk about the MCL, because it's something at all the courses, people come up to us and say, how do we physically stop ourselves from damaging the MCL? This is that aberrant branch. This is a representation of that. If you do hit this, you need to open the osteotomy to a maximal amount. It'll allow you to see that branch through the osteotomy, 20 millimeters of opening, and then you can see it, and then you can deal with it. So what we wanted to do was come up with a retractor, and here is a cadaveric demonstration. So you can see the femur, you can see the outline of the superficial MCL and the pes. So when we make the first incision, you'll see that we make a relatively small incision. And we do this midway between the front and the back, slightly oblique in the line of the osteotomy, but it's midway from back to front. And we make a smallish incision, perhaps 5 centimeters in length. And you can see us doing that. Now, for the sake of this demonstration, what we then do is, first of all, we make a more suitable incision for somebody who is perhaps slightly less expert and starting out in osteotomy. And we would say, make a bigger incision so that you can see what you're doing. And then let's now go deep to the skin and let's see what's going on with the superficial MCL. So here you can see we've got the patellar tendon at the front, and we're lifting that out of the way. And we've marked out where we would be making a biplane cut. We're not going to show that in this video. So what we want to do is we want to deal with the MCL. And before we get to the MCL, what do we do with our precious hamstring? So here you can see the PES. We pop into the bursa on top of the superficial MCL, and all you need to do is this maneuver. You open up a large clamp, and the hamstrings will fall away and give you access to the tibia. So this is a massive breakthrough in osteotomy surgery. What I'm about to show you, it's subtle, but it's an enormous breakthrough in making it safer. So if you look at the traditional approach to how we would release the MCL, we would release it a bit like in a total knee replacement. We would release it from proximal to distal with a cob, and we would come in with some sort of periosteal elevator or cob dissector, and we would strip it from the tibia. This is the classic approach. Then what we would do is we would then go around the back of the tibia and place our Homan. But actually we're fighting with the residual MCL, and we're always going to be tending to place our Homan retractor towards the back of the knee. We're in the wrong direction when we do this. So Christian came up with an absolutely fantastic idea. And the idea is very simple. Leave the MCL alone. Make a small window, a second window at the back of the tibia, just as you see here. Then place your cob retractor, and you can go all the way across the back of the tibia without touching the MCL, and you're in a perfect direction from posterior to anterior to scratch all the tissues off the back of the tibia and take yourself to the fibular head. And this was our first iteration of the new retractor, and you were then completely safe. We then start to release the MCL as we would before, and we want to protect it. There's no need to cut this. At this level, it's not the end of the world, of course, and we do release it significantly. In fact, Pudi used to cut it, but it's nice to keep this structure and to actually release it to an appropriate level to the patient, where it's not tight, but it's still remaining. So here we have a second retractor placed on top of the first retractor, and we're good to go. We can then lock that in position and place so let me just see if this is, no, I'm going to go on. So I think there's a few things here. This is a video that demonstrates that. Again, you can see the incision, and we make an incision long enough to place the plate. So we're not making small incisions. We really don't think that's necessary. Sorry, the quality of the video isn't quite perfect. And and you can see how we're underneath the MCL here, and we can pull it down in a traditional way. We don't want to do that. What we want to do is come to the back of the MCL, make this little window. Christian's done it as simply as that with the periosteal elevator. And you can then scratch all the way back across the tibia. We think this is going to stop neurovascular injury. This is a massive but very subtle change in the technique for the most common form of osteotomy. Double window. Leave the MCL alone, make a window at the back, scratch across the back of the tibia. That then allows you to place the first retractor completely safely on the bone. That aberrant branch can't be there because you can hear and feel the scratching of the periosteum. Then you can come down and release your MCL, and then you can make your cut. So we've mentioned this a few times about education. NuClip now run a course every single month in Nantes. They're just opening a big cadaveric facility. They're welcoming surgeons, And if you get in touch with me, I can put you in touch with the company, and they're doing 30 surgeons each month in their new facility, and would welcome you to come to Nantes and learn about the new developments. Once again, thank you very much. So if we could just load up my next talk.
Thank you, Professor Adrian. Fortunately, Professor Adrian will speak about the double-level osteotomies, when and how, instead of Professor Ragib, because he couldn't attend. So please, Professor Adrian, again.
So just because we started a little bit late, I'm gonna rush through this a little bit. I'll show a few pertinent slides. I'd like to have a few the and I think the session finishes in 10 minutes. So I'll just show a few slides. Oh, brilliant, perfect. So if we close this one, and then it's the final one, which is double level, perfect. So a lot of this is going to be repetitive from Akram's talk. It's all about planning, it's all about identifying the angles, and it's all about working out, is it the tibia, is it the femur, where should we correct to? So 80% of the time, a varus knee requires a correction of the tibia. 20% of the time, the varus is in the femur. For the valgus knee, 80% of the time, the valgus is in the femur, so femoral osteotomy is appropriate. 20% of the time, the valgus, sorry, it should say valgus, is in the tibia. And what we want to avoid is a joint line obliquity issue, because that will give us a bad result. So we need to look at these angles. We need to look at the mechanical lateral distal femoral angle and the mechanical medial proximal tibial angle. And these are 85 to 90 degrees, and we need to work out what is it in the patient and what do we need to do to correct them. Here you can see someone who's a little bit horizontal, very varus, and a patient of Christian's actually, and he goes on to have bilateral double levels. This lady, the same, bilateral double levels for her valgus. This fantastic paper in its time would never get published today. This is a paper that we all quote, the Fujisawa paper. In fact, the Fujisawa point was between 65 and 70%, not Frank Noyes' position of 62. But if you look at the paper, look how oblique the joint line is in their published article. And sometimes we need to do this osteotomy, as I say, double level, sometimes just femur, sometimes tibia, and the reverse for valgus. I'm just going to whiz through some of this. So here's a case. Lateral distal femoral angle high. Mechanical medial proximal tibial angle normal. The osteotomy gets done in the tibia. You end up with a horribly oblique joint line, massive MPTA. This patient doesn't do well. Another patient, high LDFA, normal MPTA, osteotomy done in the tibia, and look at this horrible joint line obliquity. This patient has a total within a year. This is the paper we always come back to, Babis's paper. It was a paper written in 2002 on double level osteotomy. Please look at it. The take-home message is, in this study, 96% survivorship at 7 years if you really look at both joint line obliquity and femoral and tibial mechanical angles. So I just want to go on a little bit about why do we do a closing wedge always in the femur? Why do we not do opening wedge in the femur? Why do we do a closing wedge? And except for if we have a short patient, a short leg, in which case very, very occasionally we do an opening wedge. This is by far the most common way of doing a DFO at the moment, is with an opening wedge. In fact, when Isakos asked me to talk about DFO, they said, please can you present your technique for opening wedge DFO? That is not what we do. We do closing wedge, distal femoral osteotomy. It's really important that we create an isosceles triangle and we get bone-on-bone apposition. These patients heal up in 8 weeks. There's no offset and we get great stability. So this shows this concept of where is the center of the osteotomy, and 2 equally lengthed cuts that when you make them, they'll make contact with no cortical offset. Again, of course, we do a biplane procedure for exactly the same reasons that we heard earlier. The position is we operate from the same side, we drop the leg out of the way. It's a very, very simple dissection. You cut the skin, you see the fascia, you incise the fascia, you lift the muscles, you're on the bone. And it's the same for the lateral side as it is for the medial side. And of course, as I say, we make the biplane, we make 3/4 of a cut in the femur from the back to the front, and then 1/4 is the biplane. So this is a historical video. Again, we've made the incision slightly bigger. This is Christian just showing off. It's absolutely ridiculous. He's incised the skin. Now he's incising the fascia. It's not a great teaching video because the window is so small, but there's the muscle. All you need to do is lift that muscle out of the way, and you're immediately down to the bone. There's a great paper about the 3 sisters, the 3 vessels that mark out the starting point for your femoral osteotomy, which you see against the bone very commonly in this position, which of course you need to cauterize, but they act as a fantastic landmark, and then you can come in and you can put your wires in. If we look at this slightly speeded up version, this is for a lateral closing wedge. So for someone with significant varus, we open in the tibia, we close in the femur, but of course we do that on the opposite side. And again, we incise the fascia, we see the vastus lateralis, we lift it out of the way, and it gives us access to the bone. And then we need to place our converging K wires. We used to place 4, that is very difficult to do. Now we just place 2 wires that converge, and we make our saw cuts. Sorry, this is making you feel dizzy. There's a retractor in position. We're now safe. Here's a bad position, there's a good position for the wire. You can see the hinge is low. You can see our hinge wire coming in and to protect, and then we make our cuts. And we make sure that the saw is as thin as it possibly can be on the image intensifier. We make the cuts, and then we can close and we can apply the plate. We've talked about the hinge screw. So the best results for osteotomy are when you take care of alignment. Analysis absolutely the key. DFO is sometimes the way to go, but sometimes also we need to consider these bigger corrections. So I think I'm going to end there. Hopefully we've got time for a few questions. Thank you very much for your attention.